I'm just going to discuss some interesting areas of laryngology. So they don't follow a theme. It's just topics that I thought for trainees would be interesting and perhaps new ideas and new concepts. Oh, it's not moving on. Oh, here we go. Okay. So first thing we're going to do is discuss some anatomy and the difference between humans and other mammals. Now, in all mammals, the larynx sits high. The epiglottis is overlapped by the soft palate. And what it means is that they can feed and breathe at the same time. So if you're a watering hole and you're an antelope, you're primed for fright in that circumstance and get away because you're not obstructing your breathing each time you swallow. And the same situation, the same anatomical situation exists in a newborn. The larynx sits high. And technically they can breathe and feed at the same time. However, if the nose is blocked, they cannot suckle. And that's not because of this anatomical arrangement. That's simply because they don't have the neurology or the nous to say, actually, I should take a breath, pull away from the teat and take a breath and then go back. So they're neurologically immature at that stage. And the reason we know that is that they're obligate nasal breathers for 3 or 4 months. Yet the larynx doesn't descend for 3 or 4 years. And on the right there, you see the adult situation. Now, the reason humans have evolved this position for the larynx is for complex communication, but it does leave a rather precarious situation in that food and drink washes over the larynx every time we swallow. Terminology. I struggled for many years to figure out why some people refer to the vocal cord as vocal fold and other people refer to it as vocal cord. This is from Gray's Anatomy. It doesn't help. The only conclusion I've been able to draw is that the terms vocal fold and vocal cord are one and the same. They're used synonymously, so there's no differentiation. An important fact to appreciate is shown on this slide. In terms of the larynx, we have supraglottis, glottis, and subglottis. The upper limit of the supraglottis is the tip of the epiglottis. The lower limit of the subglottis is the lower border of the cricoid. However, the definition of the upper and lower limit of the glottis differs ever so slightly between the Americans and the Europeans. So the upper limit of the glottis is described as a horizontal line through the apex of the laryngeal ventricle, which is shown there. And the Americans define the lower limit of the glottis as a centimeter below this line. However, the Europeans describe the lower limit of the glottis as a centimeter below the most medial aspect of the vocal cord. So the difference is small, but it does have some relevance to staging of cancer, etc. So this is a histological section through the vocal cord or vocal fold, if you like. And you can see that there's a squamous epithelium and which has a superficial, intermediate, and deep components. And the number of fibers increases as you go deeper. So the epithelium is very loosely held in place to the underlying lamina, and this allows the epithelium to vibrate. And so the vibration is from below above, and it's a ripple effect, and you can see it there on the video. And the two sides should be synchronized in their waveform. So it rises from below upwards. Now, just to go on to voice clinics and how voice clinics should be run. If you are interested in laryngology, you will end up doing a voice clinic at least. And the sort of patients you see, everyone thinks about the singing voice, but often you've got to think about voicing professionals and the speaking voice, broadcasters, etc. And they get into trouble. And if you're going to have a voice clinic, you should have access to stroboscopy. Diagnoses change 30% of the time if patients have only ever been examined with a flexible nasal endoscope. Then you need some means of assessing the voice. Now, this can be objective computer-based voice analysis, or this can be subjective measures, subjective speech therapy grabbers, subjective patient, something like the voice handicap index. Also in a speech, also in a voice practice, a voice clinic, you should have a speech therapist. And sometimes you may need to invite in, especially with a professional singer, their singing coach, etc. Now let's just talk about the value of voice analysis, voice grading tools. Now there are various computer-based voice analysis softwares, if you like, and some of those are named there, and there are others. My overall take on those is that they're not particularly reliable, and they may have some science-based value, but in the day-to-day clinic, I tend not to use them. We use the voice handicap index, and we use the voice handicap index that has 10 questions rather than 30 questions. Again, I don't think this is a particularly reliable tool. The upper limit of normal varies from language to language. The upper limit of normal even varies within the same nation. So in the UK, the upper limit of normal in the north of England will be different from that in the south of England. But what it does serve is a tool to assess the progress of the voice in a given individual. Now, you could argue that you could just use a linear analog score, and yes, you could. Grabbers is the tool that speech therapists use to grade the voice of an individual that they're treating. And with practice, I think it works reasonably well. Why have any kind of scoring system on severity of voice problems? Well, it allows you to assess changes in a given individual, and changes based on treatment and changes based on no treatment, such as voice rest or voice therapy. More importantly, it educates the clinician's ears to voice disorders. So vocal nodules, this is probably something you're all familiar with. They can be soft and early, top left. They can get bigger if the problem persists. And if left for a long, long time, they can become hard and calloused, like bottom right. And the issue here is that the patient who is suffering with a nodule is tending to make contact in the middle of the vibrating component of the vocal cord first. So there is an abnormal closure pattern, and you end up with a pressure point where you start to get local edema and then swelling. And this is a relevant time to bring up this slide, and it was originally a problem proposed by Julian McGlashan in Nottingham. And if something goes wrong with the larynx, it has other impacts on its function, its posture, and its health. So everything plays on everything else. So when you see nodules, it is not just removing the nodules that is the issue. You need to correct the underlying problem. Now, we see nodules more commonly in boys than girls, and more commonly in women than men, and you could argue that this might be related to voice use or voice abuse. That at the moment, they're always bilateral. If you've got a unilateral nodule, it probably isn't a nodule, although you can have one side slightly bigger than the other. And management is not surgery. I've put 10% there, but I would now say less than 5% of cases should come to surgery. Treatment is speech therapy, more speech therapy, different speech therapy, voice rest, etc. And do you need to treat everyone who has vocal nodules? Probably not. Some singers have a character to their voice that is based on their nodules. I don't know if Rod Stewart has nodules, but his sort of voice, that slightly rough, gravelly quality to it may well be related to small nodular change. So here are some vocal nodules, and these are some that we did take away. The other thing that you may encounter is something like a hemorrhage within the vocal cord. Often it just presents as a diffuse tracking of blood along the vocal fold, and management is voice rest, maybe antibiotic, maybe steroids, depending on the clinical state of the patient at the time. However, if it becomes pedunculated like this, then you do need to surgically remove it, and then again, voice rest, voice therapy, and maybe antibiotics, maybe steroids, depending on your time frame for getting back to performing. People with repeated vocal hemorrhage sometimes will use something like the KTP laser, and it selectively knocks off blood vessels supplying a lesion. Now, this lesion could be a vascular anomaly like the one you see here, or it could be chronic inflammation. And on a particular setting, you can use the KTP laser just to ablate the feeding vessels. Cysts. Now, many laryngologists talk about cysts and pseudocysts, and to me, I'm never quite clear if they're clear on what they're talking about. So this slide here, top left, demonstrates both in the same setting. A cyst, the histopathology definition of a cyst is a circumscribed sac lined with epithelium. That's a cyst. The item on the left fold there on the top left is a contact injury. It's an area of edema. It's not a cyst. And I would call that a pseudocyst. So cyst on the right, pseudocyst on the left. This is an intracaudal cyst, and this patient had long-term voice problems. She was a solicitor, and we strobed her in clinic, and there was a subtle impression that the right fold was vibrating less well compared to the left fold, but we couldn't say what the problem was. And sometimes you need to take a patient to theatres and just perform an examination under anaesthesia. Now, you may have an agreement with the patient that you will proceed to do something, but in a professional voice, a lot of the time we will say, well, look, let's figure out what the problem is, and then we can talk about doing something subsequently. So at least you get a diagnosis, and then you can have a balanced discussion with the patient about risk benefits, etc., of surgery. And this was one we did take away. Here we have a unilateral swelling of the vocal fold on the left, particularly on in this case. And this is what we would describe as Reinke's edema. And it's an expansion of the subepithelial space, Reinke's space. And there are various causes described in the literature. And to my mind, the vast majority are smokers. And the reason smokers are affected is that smoking damages type 2 collagen. And that's why you see those skin changes in chronic smokers as well. And what is happening is that the fibers that are holding the epithelium in place are being lost, and the subepithelial space is expanding. And I don't know why, and I've had tried to look this up. Most commonly, it presents in females who smoke. People talk about voice abuse, irritants, reflux, hypothyroidism. Worth checking, but they're not big players. The predominant cause is smoking. And there's a grading system for those that might be interested in looking up a grading system for this. Management naturally is to stop smoking. Speech therapy, you may consider surgery if the patient asks for it. If it's particularly pedunculated and obstructive, sometimes patients have stridor and they have sleep apnea related to this, but that's quite rare. Some patients, providing you're happy with the diagnosis in a smoker, may not want anything. Next topic is scars. Now, I said that the epithelium is loosely placed on the lamina propria, which allows it to vibrate. But sometimes you end up with an injury where the epithelium becomes adherent to the underlying muscle, and you lose the vibration. Not only do you lose the vibration, you end up with a phonatory gap. So the patient has an irregular voice, and they also suffer with vocal fatigue because the system becomes inefficient and they're losing air. They'll also get aches after prolonged use because the system is so inefficient and they've had to recruit extra muscles. Now, most laryngologists early in their career will decide that they're good at what they do and they've got ideas about how they can fix this. And lots of things have been trialed, and I've done a lot of procedures in the past to try and deal with this particular problem. And there are two issues. One is the phonatory gap, and the other is a lack of vibration. The phonatory gap you could simply correct by injecting something in the fold that is affected. The lack of vibration is more challenging. To date, I do not know of a procedure that will restore normal vibration in a sulcus or scar in the vocal cord. If that were the case, then Julie Andrews would be singing again. Right, so this is another examination of the larynx under anesthesia. I thought this patient just had some scarring, and you can see some scarring and there and possibly there affecting vibration. But always palpate the vocal cords. And when we palpated this one, we found a mucosal bridge. Now the temptation here is, I'm a clever surgeon, I can very neatly take this away and it will look and heal really well. The danger here is that you risk making the voice worse, and I would suggest that you leave these well alone, because they end up with a bigger gap and they've still got vibration. Sorry, it's still got absence of vibration on that side, so you will make the patient worse, and I would say leave these alone if you find them. Ventricular cysts, blocked glands, there are plenty of secretory glands around. They may or may not be as a consequence of laryngocele formation. A laryngocele occurs because there is something expanding the saccule within the larynx. Now the saccule is an outpouching at the anterior limit of the laryngeal ventricle, and some people have a big one, some people have a small one, and certain occupations may encourage it to expand. And classically we talk about trumpet players, etc., where they raise the pressure in the area above the larynx. Now, if they get really big, they become external. They extend through the thyrohyoid membrane and appear in the neck as you raise the pressure in the pharynx. Sometimes they can become blocked off and become a cyst. Sometimes you've got to be careful here. If you've got a man in his 50s who's a smoker and he's got laryngocele, beware that sometimes a little tumor in the laryngeal concealed in the laryngeal ventricle may actually be causing this swelling. CT scan is the first line of investigation for this before you plan removal. The vast majority of these can be removed endoscopically. This is an external laryngocele. This is the top of the thyroid cartilage. It had been extending into the neck, and this is some weeks later. Not completely settled yet, but it does settle. So you don't need to do open procedures for these. I'm going to go on to granulomas. Now these are real nuisance. They present over the medial aspect of the arytenoid or the vocal process of the arytenoid. Usually they're due to trauma, and the trauma quite commonly is an intubation event in the presence of a chronically inflamed larynx, and the inflammation usually there because of an element of reflux or impaired swallowing. And because it's on the medial aspect, there's constant contact and perpetuation of trauma, and it's chronic inflammation and perichondritis of the epithelium over the lining of the arytenoid. We also see it in vocal abuse, also in the presence of chronic inflammation of the larynx. Now, you take these away, and certainly in a man in his 50s who's a smoker, as I said before, is high risk for neoplasm. You want to be sure it is what it is. So you will take it away for histological analysis in most cases, or you will watch it very, very closely. If it recurs, you know what it is, and you give the patient speech therapy, give them good vocal habits, treat their reflux. And a lot of the time, if you wait, they will regress. However, sometimes they keep recurring, and you've got to think of ideas of how to get rid of them. Steroids and antibiotics have been tried, and there's little evidence for them. I think anti-reflux therapy, but you've got to carry on for many months, a year or more sometimes. If they're a particular nuisance, the thing that really does work, and you've got to counsel the patient properly, is to Botox half the larynx. And what this does, it enforces rest, it reduces that contact between the arytenoids, and the lesion will regress. However, they have at least 3 months of maybe minor swallowing problems, but certainly a weak, breathy voice. And this is going to be a hard recommendation in someone who already is a heavy voice user, but it does work quite reliably. I'm just going to mention briefly spasmodic dysphonia. This is a brainstem-based neurological condition. The vast majority of cases are the adductor type. This is where you get the strangulated, effortful voice, and a lesser number are the abductor type, where they get a weak, breathy voice. Sometimes they're mixed. 15% of patients will have other manifestations in the head and neck in relation to their spasmodic dysphonia. Unfortunately, certainly our neurologists are not interested in sharing this case mix, and they just say, watch them. If you find something, let us know. They're not prepared to screen these patients. It adds to their workload. But anyway, the differential is tremor, which you sometimes see in older patients, more commonly Parkinson's disease, and sometimes psychological. And the diagnosis, if you see enough of these, you will be able to diagnose the majority. But sometimes you're confused. You do not know if this is spasmodic dysphonia, if it is some other neurological problem or psychological. And you ask your speech therapy colleague, and they either give you an answer or they're equally confused. And sometimes a trial of treatment is the way to go forward. So you Botox the vocal folds or the posterior cricoarytenoid, depending on what type of disease it is. And they may get better, but they may get better based on placebo, but at least the patient gets better. And this is a little video showing Botox injection in clinic. And a lot of these we do under local anesthesia, spray up the vocal cords. Other treatment options, Shiki in Japan described a thyroplasty technique where you split the anterior commissure and you put a metal plate in there, titanium plate, to separate the vocal folds so that they can't spasm. And in Japan, this had to be used as a technique because Botox wasn't licensed for laryngeal use. So that's where that appeared from. Some people are now using a technique where they find the nerve to the vocal fold appearing posteriorly, and they do a laser neuromyomectomy and find the nerve posteriorly in the vocal cord, vocal fold at the back. I'm not entirely convinced about this. They find a little fiber that they think is the nerve and take it away, and a number of patients get better, but they don't all get better. And so I don't use this as a primary technique. I use this as a technique where Botox either doesn't work or has failed to work. Botox is still the most reliable way of managing this condition. I'm just going to go through some hints about when you come to theatres, how to do your surgery, use of lasers, etc., and anesthesia. I go on about this, and I think it's an important thing to be aware of, and it will help you to be more successful in performing suspension laryngoscopy. In pediatrics, it doesn't really matter how you position the baby, head ring, shoulder bolster. The larynx sits high, the baby's tissues are compliant unless they're syndromic, and you can usually get access to the larynx. In adults, it starts to become more challenging in certain circumstances. And if you want to reliably access the larynx or more, have a greater chance of being able to access the larynx through laryngoscopy, do not put anything under the shoulders. Put something under the head, a rubber guard for the teeth. If you can't get a view, you raise the head. If you can't get a view, you keep raising the head. Then you might try cricoid pressure. Then you might try a different laryngoscope if you want to. If you get a partial view, say the posterior larynx, half of the larynx, just suspend and wait. The laryngoscope is sat against tongue, soft tissue. The fluid in the tongue will dissipate and gradually the view will get better. So do not give up immediately. And this has been proven on various studies now, yet a number of my colleagues do not do this and do not follow this guidance, and so they have a higher failure rate for microlaryngoscopy than we do. The other reason we have high success rates is in the choice of laryngoscopes. If you're going to look at the vocal cords or the subglottis, I use a Dido-Pilling laryngoscope, and it will get you to the larynx 99% of the time. We don't even open an anterior commissure scope anymore. If you're working on the glottis or the supraglottis, there is a choice of scopes, and we tend to use the Lindholm, which gives you good access. Now to lasers. Now, you probably all know about lasers and Einstein's prediction of lasers and the development of lasers, so I'm not going to go into detail. But the thing to say about a laser, it's not a light bulb. It's not a light bulb where you've chosen the wattage and it gives you a certain output. It's a delicate tool, a bit like a paintbrush. Depending on the spot size, then depending on the duration of exposure, what you achieve is different. So it's not just power settings. And in most circumstances, we will use the laser in a super pulse mode. And what it means is you can reach higher peaks, yet your average energy delivery and thermal injury is not as high as the peaks. So most devices, they either have a thing called a super pulse or an ultra pulse, depending on where you bought your laser. And so laser techniques, they can be an art form or not. So be careful, there is a learning curve. And these are some of the injuries that I picked up over the years. So the top left is webbing because someone's lasered papillomata on both vocal folds. The bottom right is a bigger disaster. Again, that's the vocal cords, the glottis, and it's completely scarred down because someone's been radical with the laser treating papilloma, and you can still see some papillomas there. Now about ventilation. I'm a big fan of jet ventilation. And the reason I'm a big fan of jet ventilation is that there is nothing occluding your airway. Now, top left, you've got a microlaryngoscopy tube, and you can see most of the vibrating vocal fold and bulk of the pathologies that are in this area. If, however, your pathology is at the back, if you wanted to laser this tube will burn. You can use a Hunsucker subglottic jetting catheter if you wish, and that gives you better access. But for me, jetting is great. Not only does it give unobstructed access to the vocal folds and the trachea, subglottis, etc., it also clears the smoke when you're jetting. Currently, it's difficult to be able to use a jet because the risk of aerosolizing COVID, but we are gradually going back to it after screening patients. There is a myth about laser fires. This is a normal microlaryngoscopy tube. This is a laser tube. This is a laser tube. And you could use these, but I have set fire to the balloons on these. So I prefer not to have anything in the airway that can burn. If I've got something in the airway that can burn, I will not use a laser. You cannot combust oxygen without something flammable. And this is a myth that some people still believe can happen, spontaneous ignition of oxygen. You need oxygen for a fire, you need something, fuel, something that can burn for the fire, and you need something to ignite it. And if you haven't got something that will burn, you're not going to get a fire. So these are various jet ventilation tools. This is a Saunders handheld device. This is our original automated machine. And now we also have a twin stream system. Now, I'll just talk about Thrive, high flow nasal oxygen. This oxygen is 100% and running at about. What it means is that a patient with a compromised airway or a strictured airway can have their oxygen levels maintained, not necessarily their CO2 removed, but their oxygen levels maintained for prolonged periods. Again, this gives you free access to the airway. And for me, this is a tool for buying time for a difficult airway for both the anesthetist and the surgeon. So if you had a tumor in the tongue base, that kind of thing, or a supraglottic tumor and you were going to struggle, this serves as a great tool to buy time. A lot of people are using it around the world for ventilating the patient for laryngeal surgery. And I understand why this is. This device is cheap. The nasal prongs are very cheap. And so rather than spending many thousands on jet ventilators and modifying laryngoscopes and all sorts of other things, it is an easy way to access the airway. The problem is oxygen is a heavy gas. And there have been cases reported of fires, not in the airway, but in and around the other parts of the patient, where there are flammable items, drapes, gum guards, etc., any little ignition and the patient could go off as a fire. And so beware. It's a good tool for buying time, but it's not necessarily the answer to ventilation in total. I'll talk a little bit about papillomatosis of the larynx. We're going to see less of this with the vaccination program, hopefully. There are about 4 prominent viruses. There are other viruses that affect the larynx, but mainly 6, 11, 16, and 18. And 16 and 18 are said to be the more dangerous form. Children get it from their mothers, probably from the cervix as an ascending uterine infection. And cesarean doesn't necessarily protect you. So if you have your second child by Caesar, it's not necessarily going to prevent you getting it. In adults, they talk about sexually transmitted. I'm not so sure about this because I'm sure we're all exposed to the virus on a weekly basis. People have it on their hands, we shake hands, or we used to shake hands and then make contact with our mouths, etc. I think there's probably a genetic predisposition. The incidence is somewhere between 2 and 4 per 100,000 of laryngeal papillomatosis. However, we believe that a larger percentage of the population carry the viral genome in their upper aerodigestive tract. And it's implicated in oropharyngeal cancer, which is on the increase. Symptoms, well, you can figure it out. Depending on bulk of disease, it'll affect the voice. It could affect the breathing. The aim is for remission. Surgery is to manage symptoms, whether they be dyspnea or dysphonia. Many things have been trialed in the past. Vaccine holds promise in prevention. Things like cidofovir and avastin will, if used regularly, will reduce the rate of growth, but they do not necessarily make the disease disappear. Thankfully, the vaccination program has been, in the UK, has included boys now, which means that certainly when my son grows up, hopefully he'll have less chance of oropharyngeal cancer and maybe less chance of papillomatosis elsewhere. And the reason this has been taken up is through petitioning, but also evidence that vaccinating patients who already have the disease may reduce the recurrence rate or may even lead to remission. And the evidence is not staggering, but I accept it's a good thing that we are vaccinating boys now. Surgery. If you're doing surgery for papillomatosis, the virus grows on squamous epithelium, and its risk for malignant change in the larynx is extremely small. You will take biopsies anyway, because sometimes tumors, squamous cell cancers can look like papillomatosis. And from time to time, you need to take biopsies because even though the risk is low, there is a slightly elevated risk. The risk is greater if the virus and the papilloma spread to the trachea and bronchi. And these patients need to be watched more carefully because metaplasia has taken place for the papilloma to grow on this site. And there is and I emphasize the importance every time you do surgery for these patients, inspect the trachea and bronchi, because you're going to have to watch that patient more carefully if it's gone down. And remember, I think I may have lost signal there. If you're performing surgery, you're performing it to improve the voice and airway. You do not need to be radical. Removing everything you can possibly see is not necessary, because even some of the normal epithelium will have the viral genome, and you're not going to go after that because the damage will be unbelievable. However, there is an argument that reducing bulk reduces how much virus is shed into the airway. What do I like to use for surgery? I'm a fan of the laser, but I will use a microdebrider in some circumstances, certainly in the trachea. I'm not a fan of the co-blator, as it respects no boundaries, and in the wrong hands, it could be a disaster. So for the sake of time, I'm just going to move on. The only point to make here is that if it's bilateral disease, in this case, I will leave a little bit of disease at the anterior commissure on one side, come back for a month later, otherwise you risk webbing. I'm talking now a little bit about tracheostomies and its impact on swallowing. I'm a big fan of percutaneous tracheostomies, and these became more popular amongst my ENT colleagues during the COVID crisis. And I think we should all learn both techniques, surgical and percutaneous. The early complication rate is actually less with the percutaneous technique, providing you use some sort of endoscope to visualize the airway as you do it, because you don't want to puncture through into the esophagus. The early complication rates are actually greater with the surgical technique. But there's a place for both, I believe. The long-term complications are no different between surgical and percutaneous techniques. With respect to swallowing and tracheostomy, if we just talk about the safety of swallowing, we all know that for a safe swallow, the neurology needs to be intact. And what happens is the vocal cords close, the false vocal cords close, the larynx rises up and tucks behind the tongue, which moves backwards. But you may not all be familiar with the fact that majority of the time when you swallow, unless you're thinking about it, it's during an interrupted outbreath. What this gives you is some subglottic pressure during the swallow. It also gives you some respiratory reserve if there is an aspiration event, just to cough and clear the throat. Conditions that cause dysphagia, there are numerous, and you can look these up. And I'm not going to dwell on those. What we are aware of is that the swallowing becomes less efficient as we get older, and that's like a lot of wear and tear and deterioration in function with age. And there may be comorbidities and drugs that impact on it. And if you're investigating swallowing, the bulk of investigations are either video fluoroscopy or a fiber optic evaluation of swallowing, a fee study. Sometimes we will use manometry. But back to tracheostomies for dysphagia. A tracheostomy does not cure dysphagia. However, in an acute situation such as a stroke, with intensive nursing care, you can have regular suctioning and make sure that the secretions which still enter the airway are managed, and these are easier through a tracheostomy. So the problem with the tracheostomy is, one, it fixes the larynx in the neck, and so that elevation behind tongue base is impaired. But that will depend on the size of the tracheostomy. If you've got a tiny little soft tracheostomy, it's going to have a less of an impact than a huge solid size 9 in a woman tracheostomy. And placing valves on the tracheostomy, or even removing the tracheostomy, improves the swallowing. So there is conflicting evidence in the literature as to whether a tracheostomy helps or does not help dysphagia. It's a variable thing. The biggest issue is related to the size of the tube and how much the tube fixes the larynx and its elevation, but also that interrupted outbreath, that subglottic pressure on a swallow, that becomes absent when you put in a tracheostomy tube, and removing the tracheostomy tube will restore that particular problem. Where the swing is barely safe, is borderline unsafe simply because of wear and tear and age, a tracheostomy will have a huge impact, whereas in a younger patient, it will have a lesser impact. My last topic that I'm going to cover is problems related to dysfunctioning laryngeal airways. And there are many terms banded out there. There are dozens of terms, and there are various topics, various conditions, I think, that come under this subject heading. And we talk about VCD, we talk about paradoxical vocal cord motion, and there's Munchausen's and all sorts of other things, terms that are used for these conditions. There's also a separate condition, I think, then it needs to be separated, of laryngospasm, and I'll talk about why that's separate. And there are things such as exercise-induced laryngeal obstruction. Now, the thing that annoys me is that there has been a working party of the European Laryngological Society and the European Respiratory Society, and they've sat together and they've come up with this term, inducible laryngeal obstruction. I don't think it's a very helpful term, but they've brought it out as an umbrella term to cover all of these conditions, including EILO, which is exercise-induced laryngeal obstruction, which we've traditionally called ILO. Now they've got a new term, which is ILO, which we call ILO, and it's all very confusing, and they should have thought about it a bit better. I like the term a dysfunctioning laryngeal airway as an umbrella term. If we talk about VCD, or paradoxical vocal fold motion, these are patients who present repeatedly to the emergency department with complaining of shortness of breath, struggling to breathe, and they're making noises that are stridulous. And they're treated as emergencies, they're treated as allergy, as asthma, as all sorts. They get steroids, they get observed, they don't seem to be getting better, and then someone decides, well, this can't be sustained, and these patients end up being ventilated with a tube, and then suddenly someone discovers that the ventilatory pressures are minuscule or normal, and the patient is extubated the next day and goes home, and the cycle is repeated. If you're called to see these patients, look carefully with an endoscope. Obviously, if you think there may be epiglottitis, then don't be passing an endoscope and be more sensible and go down that pathway. But if this is a repeat offender, have a look with an endoscope and see what the vocal cords are doing with respect to breathing. Get the patient to say E and sniff, and repeat that E and sniff, and see if there's indeed paradoxical vocal cord movement, or whether the vocal cords aren't moving adequately, what the situation is, and believe what you see. These cases are often associated with cough, voice problems, and a globus sensation. Now, within the realm of abnormal vocal cord movement, there are three entities. One is where you have persistent paradoxical vocal cord movement, the bubble on the right. Then you have patients where they intermittently have paradoxical vocal cord movement, and these are patients that intermittently present to the emergency department. And on the left, you have patients with laryngospasm. Now, I will separate laryngospasm. I'll talk about etiology for the other conditions first. Patients complain about irritants, allergens, this kind of thing. A lot of the time, I would say there is psychology behind this. It may be a conversion disorder, post-traumatic stress, some childhood abuse issues that need to be brought out. With respect to laryngospasm, it's a distinct subtype, and it's a hypersensitized larynx, whatever the hypersensitizing event may have been, maybe reflux, maybe previous viral type illness. It comes on suddenly. It comes on like a light bulb, flick of a switch. It doesn't come over hours, just sudden onset. It lasts for up to a minute or so. It's very much like the spasm you see at extubation sometimes following surgery. And some patients start to feel faint, but as soon as they start to feel faint, they come around as muscles relax. This is the only subset of these conditions that will respond to Botox, because you reduce the effect of the muscles that cause spasm. Botox may work in the other forms of abnormal vocal cord movement, but only if you're managing these patients, please share the pain and do it within in a multidisciplinary setting, respiratory physician, ENT, speech therapy, respiratory physio, and a psychologist. The other condition that comes under this heading is exercise-induced laryngeal obstruction. And this you see in young adults, extreme athletes. And what is happening is that the laryngeal supraglottic structures, the aryepiglottic fold, and the cuneiform cuniculate cartilage, you can see that they're bowing in. The vocal cords are widely abducted, but you get this little bit of bowing effect. And in most people, this will have no impact. But in an extreme athlete, this generates turbulence, and they're aware of it. And it gets worse the heavier they exercise. You can see how these are bowing in now to a greater degree. A number of these patients are labeled exercise-induced laryngeal obstruction, exercise-induced asthma. But we're now aware that Up to half of the exercise asthma is in fact exercise-induced laryngeal obstruction. The diagnosis is done with a nasendoscope in place and performing extreme exercise. And the surgery that pretty much fixes the problem. There is sometimes a breathing pattern problem that needs to also be corrected, and this is where speech therapy will come in, is to just excise off those superstructures. And this is the case in theatre here. And it's very much the operation that we do in pediatrics for laryngomalacia. You divide the aeroglottic folds, but you definitely take off the cuneiform cuniculate cartilages. So I'll just show the one side. And so we divide the aeroglottic folds and just take away those cartilages that flop in. And we do the same both sides. And I'll just go on to the next slide, which gives you a pre and post. So this is another patient where you've got that folding in of the aeroglottic folds with the cartilage within, and top left, you can see the patient afterwards. Now, for most of us, we don't generate enough negative pressure to precipitate this kind of phenomena. But in athletes, this can make the difference between no medal and a gold medal. So there are a number of patients we treat within our multidisciplinary team. Now, that's the end of my selected topics, and I'm open to questions.
Thank you very much, Mr. Sandhu. That was a really informative talk and a great overview of common problems within laryngology and some really helpful tips. We've got a few questions. So first of all, we've had 2 questions on a similar topic. Would you ever MRI for spasmodic dysphonia?
We used to do this regularly. So new case, new presentation, we would MRI. I think we do it less so now, but I think if you're starting out, it's a good argument because there may be some other neurological condition. I must say I've never found one, but the guidance has been to MRI the brain in these patients in the brain stem. We used to try and seek a neurology opinion, but as I said, they're not very keen. It just adds to their workload. But most of the manifestations will be other dystonias in the head and neck rather than progressive neurological condition.
Okay, great, thank you. And would you try benzodiazepines in vocal cord dysfunction?
Benzodiazepines, if it helps with anxiety, there are a lot of drugs that are tried, amitriptyline, benzodiazepines, various inhalers and things. Worth trying. I tend not to prescribe it. I get the physicians to prescribe it, but it's like a plaster on a problem. You've got to get to the underlying problem, and if it's a psychological issue, then you really need either the speech therapist or the psychologist to get to the bottom of that. More and more I see, the more and more I think this is some sort of conversion condition. It's maybe a cry for help, oversimplistic, but you know, share the pain with the team. Don't suffer these patients on your own.
Okay. Fantastic, thank you. In terms of, you mentioned some very helpful tips to juniors in terms of positioning the patients for laryngoscopy. Had a question for esophagoscopy. What's your preferred position?
So the 2 positions are different. Trying to achieve is flexion within the cervical spine, extension at the atlanto-occipital joint, but also extreme flexion at the cervicothoracic junction of the spine. So it's sticking your chin forward. What you're doing in esophagoscopy is trying to straighten the spine and extend the atlanto-occipital joint, the sword swallowing position. So in those circumstances, what I tend to do is put a pillar under the shoulders. So by doing that, you drop the cervical lordosis, but you also drop the thoracic lordosis. So you straighten the spine, then you extend the atlanto-occipital joint. And using a pillow, because normally when you do an esophagoscopy, quite often it's part of a pan endoscopy, and it allows you to move the head this way and that way. These are not things that you want when doing microlaryngoscopy, because you know where you want to go, and that's where you're going to stay. So you stabilize the head with a head ring, and partly it raises the head. So slightly different, and what you're and a lot of my colleagues wouldn't be able to describe that anatomical difference between the two approaches, but there is a distinct anatomical difference.
Great, thank you. And what is your workup pathway for unilateral vocal palsy?
Okay, I deliberately didn't discuss that because it would have been another half an hour of the talk. So history is important. Why have they got it? A number of them are through quite commonly idiopathic, and we talk about viral processes, even though this has never been proven. Some of them are iatrogenic, thyroid surgery, thoracic surgery. Some of them are due to neoplasm. So certainly you will examine them in clinic, having taken a history and determined if it's just the voice or swallowing that's also affected. The swallowing is likely to be affected if it's a high injury because you affect some of the supply to the pharynx. And the position of the vocal cord, is it just immobile? Is it prolapsed? Is it wasted? Is it how lateralized is it? You'll do some voice analysis to see what the phonatory time is, etc. So all of these things are important in clinic. I guess what you're leading to is what is the absolute test to look for other etiologies before you call it idiopathic. And for me, that is a CT scan that follows the path of the 10th and the recurrent laryngeal nerves. So that's from brainstem to the middle of the chest. Now, some people prefer an MRI, and that's fair enough, but an MRI is less good in the chest, whereas a CT scan is reasonably good for most of the path of the nerve. So they all get a CT scan, unless you already know why it's there. If you've got a tumor mass, but then you want to image to determine what the extent of the tumor mass is. So CT scan is my a preferred investigation for most of these patients.
Great, thank you. And further question about jet ventilation for laryngeal papillomatosis. Is there a potential risk of seeding the papillomas?
So yeah, it's odd that people can have a high burden of disease in the larynx, and the virus is shed all the time from these papillomas. And each time we breathe in and out, we're shifting the virus in and out of our trachea, our lungs, airway, etc. And yet it is surprising that more patients, and we don't know what the process is for the patients that do get tracheal and bronchial papillomatosis. Again, is it another genetic susceptibility? Yet not many do. So yes, jetting will seed the virus to the trachea and bronchi, but I am not aware of any case where I've had a patient where I've knowingly seeded the disease, because as I say, you breathe in and out, you go for a run, you're generating high pressures in and out. Theoretically, yes, but I've not seen any convincing cases. Otherwise, I wouldn't use jet ventilation in these circumstances. The other question then will be about the laser and laser smoke, and does it carry the viral genome? A theoretical risk, not proven. We're actually looking at this at the moment. We're filtering smoke and seeing if we can identify viral particles. But again, the evidence is not there. But you should protect yourself, and your staff should protect themselves with laser masks.
Thank you. And in this COVID times, any other tips with regards to protecting yourself?
Even with proper screening for COVID prior to surgery, there is still a sort of 5% risk that the patient may be positive. So you should protect yourself, wear a mask, wear a visor, wear an appropriate mask, BP3 if you can. Jet ventilation, I accept, is aerosol generating. But because we do a large number of airway cases, we have no choice in these circumstances. So my colleague and I have accepted that where it is life-threatening for the patient, we will use the jet now. We didn't for a long time. We just used intermittent apnea, intermittent intubation of the patient. But that's not ideal, especially in an obese patient where you get no time at all. So we are going back to jetting, but yes, it has the risk of aerosol generation if a patient is positive.
Fantastic. Well, thank you very much, Ms. Sandhu. That was all our questions at present. We're really grateful once again for you joining us and for giving a really informative talk and a great overview of laryngology.